Let's talk about sleep-related eating disorder. So this is a parasomnia, and also is classified as a form of sleepwalking. It presents in early adulthood, and it arises out of non-REM sleep. And because it arises out of non-REM sleep, it occurs in the first half of the night, and I'll explain why that is later. So it can also be comorbid with restless leg syndrome and sleepwalking. And importantly, it can be precipitated by zolpidem being the most commonly implicated medication, but also other psychotropic medications as well. So in order to understand why parasomnias that are arising out of non-REM sleep occur more in the first half of the night, it's important to first look at what a normal person's sleep architecture is. So during the first half of the night, the first 3 or 4 hours, someone is in N1, N2, or N3 sleep for most of that time, and N1 through N3 being the non-REM portions of sleep. And only rarely do you go into REM sleep, and only for a short time. And as the night progresses, though, the periods of REM become longer and more common. And so that's why non-REM parasomnias arise more in the first half of sleep, and REM-related parasomnias arise more in the second half of sleep. So for the clinical features, the hallmark is that there will be recurrent episodes consisting of arousal from sleep followed by dysfunctional eating. Importantly, these episodes have impaired consciousness and impaired memory recall, so this will differentiate this parasomnia from eating disorders such as binge eating or bulimia. You'll also eat inedible or toxic substances such as frozen food or cat food, or more toxic substances, and sometimes patients can poison themselves. Injuries do occur during the episodes because you have impaired consciousness. You're not able to avoid walking into things. And there can be adverse health consequences, with the most common one being weight gain, and otherwise other people can have diabetes. So in order to diagnose this disease, you must exclude medication side effects such as from zolpidem or from other psychiatric medications, as well as untreated medical or psychiatric conditions. Some of these conditions can include obstructive sleep apnea that's untreated, or psychiatric conditions. So the evaluation of sleep-related eating disorders consists of ruling out other diseases, such as seizures. So the difference between seizures and sleep-related eating disorders, just based on history, is that seizures are more stereotyped, simple actions, while sleep-related eating disorders, you'll have more complex actions, walking and cooking food, eating it, and then going back to sleep. And on the sleep study, you'll also be able to rule out other comorbidities such as obstructive sleep apnea. Restless leg syndrome is more of a clinical diagnosis, but you'll also want to rule that out. The reason being, if you treat these other comorbidities, your sleep-related eating disorder may become better as well. So for treatment, topiramate is the treatment of choice, and it reduces nighttime eating episodes, and it also causes weight loss as well. The most commonly reported side effects of topiramate include cognitive dysfunction and paresthesias. And I want to emphasize again that you do want to treat the comorbid conditions such as obstructive sleep apnea or restless leg syndrome. Now during an episode, what you can do is you can basically just lead the patient back to bed. You don't have to wake them up, as that will cause them to become disoriented and potentially violent.